the same Hewlett-Packard, I think.
Oh, we ditched those and went over to Dell. Or Mr. BT did at the time.
Right, okay then. I thought it best we start with respiratory viruses, as this is quite an entertaining time of year for respiratory viruses. Okay, the regular graph showing 4 different groups of viruses and where they're going in terms of, are they increasing, are they decreasing? And we can see RSV has increased a little bit from a very low level. So maybe we're beginning to see a steady increase in the virus you've just been talking about. This is last year, so we were obviously at higher levels this time last year, and it's only really making its way up now, but it's got potential to go quite high. So whoops, go back, there we go. Rhinovirus was shooting up last time we talked last month, but it's fading fast now, so the common cold has been and gone. The big one we're worried about, well, there's 2. The COVID is fading away. We were worried about it gradually building and building and building, and it just in the last month it seems to have faded out, which is good news for us. But in exchange, almost in parallel, influenza is shooting up, and it's shooting up from around about the end of September, which is early for flu. So that's a bit of a concern. And I've gone to find some more information on this for everyone. As usual, there's a lot of information on the UKHSA website, but this is just interpreting that. This is the link of the page of the post I wrote about the flu earlier this week. And essentially, the UK, just as I've just been saying, the flu season has become much earlier and is progressing much faster than usual. So it's looking like quite an aggressive year. This is a good time to obviously get your flu vaccine. Cases are now surging. The dominant strain this year is of particular interest. It's a drifted influenza A, something called an H3N2 variant. So it's an H3N2, which has probably been around for some time, but it's they're calling it a clade, a slightly different subgrouping, which makes it easier to spread. Like with all these viruses, when you get a genetic variant, it's all about does that variant enable it to infect more people? And if it does, it tends to overtake everything else. Normally, oops, I keep doing that. Normally, this means that it's not, if it was COVID, I would say that probably means it's not as likely to give you severe symptoms, because something that spreads faster generally is less virulent in other ways. But this, as we all know, influenza A has been around an awful lot longer than COVID. So maybe this is what happens when you get, I don't know, 150 years into the outbreak of an influenza. Back in, I think the late 1800s was the first one. And obviously the big Spanish flu was in around 1918. This particular one is more likely to cause symptoms. It's a couple of direct cases I know of people who've literally had to take to their beds because they've got this flu. Lots of aches, lots of shivers, lots of sweating, lots of coughing, about as bad as flu gets, I think. So this sounds like it's quite a nasty flu, and that will certainly test the capacity of the NHS over the next few months. Generally, these things peak around Christmas, New Year, and then start fading away. Maybe this one's going to peak a month earlier than that, which might be in what, 2-3 weeks time. So worth taking precautions. Almost all of these cases are of the H3N2, and this is consistent across GP, hospital surveillance and community surveillance. This is definitely something that's loving to spread in the UK. It has evolved slightly away from the strain that was used to develop vaccines this year, meaning the vaccines may be slightly less effective against this particular strain. Yep. So, but it's still effective. Despite the drift, the flu vaccine is providing important levels of protection in children, which is the group that we probably worry the most about, I guess, for flu. It's 70–75% effective at keeping kiddies out of hospital, I presume that means. Not quite so effective in adults, but still a very useful amount of protection. And of course, it will reduce the effectiveness of most people's symptoms if they've been vaccinated, which is great. It dramatically reduces the severity of those symptoms. Why does this matter for people with lung conditions? If you have any of the lung conditions that I know you guys suffer from, ABPA, bronchiectasis, asthma, other chronic lung diseases, flu, apart from flu itself causing hospitalization, as you probably are aware, it causes secondary infection, it causes pneumonia, it causes chest infections, and recovery times can be elongated. These H3N2 seasons are historically worse for adults and people with underlying respiratory disease. This particular strain comes and goes, slight variance year on year. I don't know when the last spread was of H3N2, but there's been at least a couple of other seasons where that's been the dominant strain, and in those seasons we had worse symptoms for adults and people, particularly with underlying respiratory disease. So this one is something worth taking note of, worth trying to avoid. Obviously, the first line of attack is get vaccinated immediately, and I think everyone has already said they've been vaccinated. I haven't been vaccinated, so if I disappear from view for a week, you know what's happened. I just haven't. I haven't been asked to have it done yet. I'm used to the NHS appearing at the end of my desk saying it's time you had your vaccine, and they haven't appeared this year. So maybe I need to go and get it. But I haven't had a bad flu. I've only ever had flu a couple of times in my life, I think. And I tend to be all on my own in the corner, so I'm not going to catch it from anybody in work. Be extremely cautious in high-risk environments, and the benefit of having come out of a pandemic with COVID is the same rules tend to apply for other respiratory viruses. Steer clear of places like we've just been talking about. Schools, young children are high risk people for the next couple of months. Public transport, as Beth will attest, is often full of people coughing and sneezing, and it's difficult to avoid those people in the buses and on the trains. Healthcare in hospitals, GPs. If those buildings are modern, then certainly a GP has a minimum level of ventilation in buildings that hold GP surgeries. So, and in the waiting rooms, it's actually set out in the contract for GPs that they have to have a minimum level of ventilation, which is why a lot of them are modern buildings. So the chances of infection in your GP waiting room is minimized, but still not out of the question. So we would certainly say still go to your GP, or maybe get a phone appointment or something. Don't ignore the rest of what's going on just for the fear of catching the flu. Large indoor gatherings, as we know, this is very difficult to predict. During COVID, we've had large indoor gatherings at restaurants in other parts of the world, and they've done studies on them, and people directly in front of people with COVID haven't been infected. people on the other side of the room have. Flu is likely to be similarly kind of random. So we know that if you go into a crowded indoor setting, ventilation is poor. And at the very least, you should have a couple of windows open to promote circulation. And you're in there for a minimum of 15 to 30 minutes, then your chances of being infected with the flu are rising all the time. So best to avoid that kind of scenario for a couple of months. Poorly ventilated rooms. Winter protection behaviors. Ventilate indoor spaces when you're at home, especially if you have visitors. Bring back the face masking for crowded indoor areas. I think everyone's used to that now, so I don't think there should be any problem with that. I remember, having said that, a year or two ago, people were starting to pick on people wearing face masks. But now we're going through this. I think there's a perfectly good reason to protect your own breathing and other people's breathing by wearing a face mask for the next couple of months, probably. Wash your hands frequently, singing happy birthday as you go. We're all very well trained in this now, and obviously if someone's unwell, try to avoid them. If it's your partner or one of your children, find an offshore island where they can live for a couple of weeks. It's probably the only safe thing you can do. But we have to go. In that situation, just make sure the ventilation is good and you stand as good a chance as any of not getting it. Yeah, so I think just take those precautions. Anyone with ABPA, bronchiectasis or asthma, if you get a sudden fever, a sharp rise in cough, so people with ABPA tend to cough all the time, but if you're getting flu, the cough rate goes up, the cough type goes up, you get sputum, chest tightness, breathing changes, any of those things. Was that a cough I just heard? Any of those things are early warning signs of the possibility of getting the flu, and at which point you need to contact your GP or respiratory team, as you may well be needing protective treatment over the next few weeks. I'm not sure if antiviral medication applies for the flu. I've not heard of it, but they're quite commonplace now. So one of the things that could happen if you take on an early warning sign, get to your GP, they may offer you an antiviral medication, which will damp down the process, but you must take those as soon as possible. So it kind of depends on you getting that appointment with your GP within a day or two. After 5 days, there's no point because the virus has already done its business. Summary: the flu is now surging across the UK, driven by what they're calling a drifted H3N2 strain of the flu. People with underlying lung diseases should take this season particularly seriously. This looks like a nasty one. Vaccination remains strongly protective, but this is slightly drifted, so additional precautions are probably a good idea to help prevent you getting infected. This is all in that page I wrote on aspergillosis.org if you need reminding, and we'll put this up on video as well, recording of this as well, as soon as I can get that. Last month's video has been done incidentally, but there's virtually no bit that everyone doesn't appear in, so there's only about 20 minutes of actual information in it, so I have to finish that off shortly. I'll do that this coming week. Couple of points, and there's actually 3 points of things coming up that I should tell you about because that affects this group. 2 different groups want to come and talk to us. Chris Cosmidis, the lead doctor of NAC, will be holding a discussion or essentially giving a talk pretty much how we do on one of our Friday meetings, about his current research project, which is happening at the moment on interferon gamma used to treat CPA. Part of the what we're required to do when we get given a grant to do this type of trial is that we're asked to hold focus groups and talk to patients about the trial and get their opinions on the effectiveness of the new drug if they've had it, things like that, things how they think we're going around about doing the trial. Is it good, and that type of thing. Almost any subject you can think of. But Chris will run that discussion at one of these groups for about, I would say, probably about an hour, and he will be looking to get feedback around what he says, and then we can say we've consulted patients about the use of this drug. You might not like the idea of having an injected drug. You might be worried about something, having the drug to treat CPA. You may have misgivings, you may have advantages about it, we don't know. That's the forum in which is your opportunity to discuss and mention and talk about this particular trial with Chris. Beth has also been involved in running this trial, which is
just a little.
Which is great. Another a pharmaceutical company, Argenex, were directed towards us because they the ethos of their company is that they do everything led by patients. They want to be led by patients as much as possible in the development of their particular drugs. And this particular one they're talking about is quite a revolutionary new approach to helping people who suffer from a lot of mucus plugging, and of course ABPA and bronchiectasis are two of those illnesses. And this group is one of the few that they can come and address about this. They want to come and talk about it. Essentially what they're doing is using antibodies, to a bit like a biologic, but it's for mucus plugs. And the antibodies are they've already done a lot of work on this, and they think they can get plugs recognized by antibodies, and if they can do that, then they can target medication onto those plugs and reduce the amount of plugging. What they're mostly targeting are crystals that form within the mucus plugging, which are the parts of the worst plugs that you get, the ones that get really stuck. So they're hoping to be able to make it easy to shift those. They want to come and talk to this group. It was not going to happen this year now. We were hoping it would happen in December, but another meeting I'll mention in a second gets in the way of that. So we couldn't do that. So it's going to have to be early next year that they come and talk to us. So that should be really interesting, because this is a new approach to me. I've not heard of this before. And it's one of those things that could make a big difference and be really low risk, but make a big difference to people's actual symptoms, especially people with ABPA. And also people who are having bleeds, which is often caused by these structures within mucus plugs, damaging the walls of your airways. So it could improve that as well. The fact that they're coming to talk to us about their research, and they'll be looking to start a trial middle of next year, we may well be able to get involved in the trial as well, which could be really useful.
Yeah.
Which some of you might want to talk about when they come and talk to us.
Absolutely.
Yeah. So that's cool. Just a note, it's not written down here, just a note that we are having our annual meeting with commissioners on the 1st of December, so in a couple of weeks' time. And they want us to have 1 or 2 patients talk to them about their experiences with NAC. These are the people that fund NAC, and then you are the people that fund NHS England. you're members of the public, you are the people directly benefiting from NAC, and they just want your opinion on whether their money is being well spent. It's as simple as that. If you want to, we need a couple of volunteers. CPA or ABPA or basically anyone who wants to talk about it. I would encourage to just talk to me, send me an email, whatever, and we'll line it up. It's all online. I remember we've done a few of these over the years where everyone came in here, including the commissioners. But this would take place online now. At least the patients partaking will be online. You won't be exposed to the people directly. You'll be online. So let me know if you're interested in getting involved in that. And now, right. So how are we doing for time? Oh, this is pretty good. Okay. So what with all the thinking and reading that we all generally do, I wanted to come up with something to talk about around research for aspergillosis. I write a lot of these things into these articles that I'm writing every week. I think a few of you are receiving those emails which list all the things that I've written in every 3 or 4 days. There's about 200 of you receiving those, so that's kind of useful. I hope it's useful to you anyway. Anyway, one of those subjects was ABPA and how we have always looked at ABPA as a disease. It's actually a kind of odd disease. Over the last 20-30 years since it was identified, we have always considered ABPA, or doctors have always considered ABPA as an allergic response to a fungal infection. And that's great, and that's fairly clear. And something that we did here at NAC was try to support that model, because we call something like this, that statement describes a model, and now we've got to test that model. And what we did 15 years ago or so, maybe a bit longer, is give, if ABPA is caused by a fungal infection, if we treat the fungal infection, then those patients should improve. The symptoms should respond to antifungal treatment. And indeed, so that's what we did. And there's a paper that's been cited about 1,400 times now, where we gave ABPA patients, in fact, I think it was a SAFS patient, a group of them, antifungal medication, and then recorded improvement in their symptoms. And the measure we used for that is that those patients needed fewer oral steroids during the period of time that they were on antifungal medication. Now, you know, and I know that antifungal medication can be quite strong medication and cause other symptoms. So it was complicated. How do we distinguish what's a side effect? And some side effects are suppressed by oral steroids. It's difficult to make up your mind what's causing what in this situation, but we very carefully worked our way through that, and we did come up with a nice paper that showed that if you give ABPA patients antifungal medication, their symptoms improve. Therefore, it must be a fungal infection contributing to ABPA, because if the fungal infection, even though we'd found fungus in the airways, although we don't find an awful lot in the airways, if we treated it and killed it off using antifungal medication, it must be the fungus causing an infection, causing those symptoms which have been relieved. So for a long time, that's been the model, the proof of the model. We give antifungals, they help us reduce the amount of steroids that you take, therefore ABPA must be partly a fungal infection. Seems perfectly logical. However, nowadays we've got biologics. ABPA is fundamentally an allergic immune-driven condition, not a true fungal infection in the classical sense. So even though we've got evidence that says the fungal infection is an important part of it, biologics tend to suggest to us that that's not the whole answer. So fungus Aspergillus is usually there, but the Aspergillus fungus isn't, we don't think it's actually doing damage. All it's doing is causing the immune reaction in your airways, and all that mucus and all those plugs are a result of that, are a result of your immune system overreacting, and not a result of the fungus invading the tissue. We know the fungus doesn't really invade tissue, except in about 10% of patients. We seem to get something that resembles CPA starting to happen, and we're keeping a close watch on that situation. It takes a long time for that to happen, so we don't have many patients to look at yet, but as time goes on over the next 10 years, we might be able to study that happening. But at the moment, we're not quite sure why that happens at the moment. But at the moment, ABPA is caused, the damage to your lungs is mostly caused by your own body overreacting to the fungus. And of course, the fungus doesn't go away. It stays there unless you give it an antifungal medication. As I mentioned, we now have biologics. And what do biologics do? They suppress inflammation. So biologics are teaching us something, a new thing, a new tool for us to show what is important for the symptoms of ABPA. Biologics suppress inflammation, and type 2 inflammation is allergic inflammation via all these different interleukin pathways. When people who've taken biologics, their symptoms improve. The number of mucus plugs they get reduces. The number of exacerbations reduces, sometimes even down to naught. They reduce hospital admissions, and they normalize blood tests, so they have an impact on IgE and that type of thing. They do all of those things, which is almost all of the symptoms of ABPA. And in some patients, they almost feel like they haven't got ABPA anymore, which is amazing and fantastic. But what they're not doing, because they are not antifungal drugs, they do not kill or remove the Aspergillus fungus. So if the most important thing is an Aspergillus infection, why, when you don't do anything about the infection, are you managing to treat almost all the symptoms of ABPA so effectively? And that kind of changes our impression about what is important in ABPA patients. Because in ABPA, the immune system is the main problem. It reinforces the impression that we had from giving steroids. I mean, steroids were giving us part of the answer, but the oral steroids are kind of a blunderbuss weapon. They knock out all sorts of things, not just inflammation. So they're not very precise. So even though there was a hint that it was about inflammation, oral steroids aren't really giving us the definitive answer. Biologics, on the other hand, are incredibly precise. And we know that there's 4, 5, 6 of these now that can relieve the symptoms of ABPA, but none of them are affecting the fungus. So this strengthens the idea that actually we don't need to worry about fungal infection. All we need to do is treat the immune system. So is ABPA a fungal infection? And the answer is no, not in the usual sense. Not in the sense that CPA is a fungal infection, because chronic pulmonary aspergillosis, we've got colonies of the fungus. I shouldn't use the word colonies. We've got aspergilloma. We've got balls of fungus growing. We've got fungus growing in people's cavities in their lungs, causing cavities to expand. That's a fungal infection. That's a fungus causing damage to your lungs. ABPA The fungus isn't doing that. ABPA is an allergic disease. It's a reaction, an overreaction of your body's immune system to the presence of the fungus. That's what it is. What it is not is a fungal invasion of tissue, like CPA and invasive aspergillosis. And it is not a traditional infection where the fungus destroys lung tissue directly. This seems subtle, but there is one or two important outcomes of this. So in ABPA, so what we're looking at is Aspergillus is there in your airways if you've got ABPA. It's there in as far as we can measure, and it's difficult to measure in a reasonably high amount. But it's there as what we've called a colonizer. It's not actually there as a pathogen. It doesn't invade tissue. It's not pathogenic, acting pathogenically. It's just its presence is causing these symptoms. And colonization of your airways is a relatively new concept, because we always thought the airways of what should I say, a well person, a healthy person, were sterile, but genetic diagnostic techniques where they run samples through DNA analyzers have shown us that our airways are anything but sterile. They are absolutely full of all kinds of microbes, fungi and viruses. And Aspergillus is one of the main fungi that sits in everybody's airways, essentially, because we're breathing it all in. Aspergillus is in almost every breath we take. We're breathing in Aspergillus. It's there, but it just colonizes. It doesn't invade. The immune system overreacts disastrously, and not entirely sure there's a genetic elements around that, and particular context around it. But the immune system of someone with ABPA, for some reason, completely overreacts to the presence of Aspergillus as a colonizer, not a pathogen. And that's what causes the mucus plugging, the coughing, the bronchospasm. Eosinophilic inflammation is a reaction to the fungus sitting there. IgE is a reaction to the fungus sitting there. And the corresponding long-term damage is bronchiectasis in people with the ABPA, where the airways are distorted essentially by mucus plugging and that sort of thing. The damage is from inflammation, not from fungal growth.
Graham.
Yeah.
Can I ask you a question while that's
of course
fresh there? The last time I was in clinic, the doctor said to me about the Scedosporium, because they've always said, over the years, they've changed the way they described the Aspergillus.
Yes.
And eventually Professor Denning said to me, it was basically Aspergillus bronchitis. And then he said, with the Scedosporium, he said that was Scedosporium bronchitis. And then last time I was in clinic, the doctor said to me, similar to what you've just said about the Aspergillus being colonized, he said to me, they reckon that the Scedosporium, that the longer time goes on, and they're looking at these sort of presences in the lungs, he said that they reckon now that the Scedosporium and the Aspergillus are colonizers.
Yeah.
But I always, before I got the Scedosporium, I had noticed that there was a really big difference. Once that started, something changed in my lungs. Everything changed, particularly the amount of sputum I was expectorating, and the way it was building up and the way my lungs felt. So I could feel symptoms, but then they say they're colonizers.
Yes.
But what you've just said then about the inflammation, so is it possible that the colonizers, the fungal colonizers, are in effect making the bronchiectasis work, because as time's gone on, over the last intervening period since I had the last scans, the mucus plugging and the inflammation at the bottom of my lungs and as really got worse. That's what they've said to me. And then
Yeah.
I've had this other scan, 6 months break in between before this most recent scan, because of some changes in the right lung. So is it possible then that the colonising of the fungal infections are making the bronchiectasis work worse than it would normally be in people who don't have fungal presences?
You just got to go back to my desk. Hang on a sec.
Yeah,
Yes, I think so.
right.
Essentially, well, that's what ABPA is, isn't it? It's a colonizing fungus that's stimulating. So Scedosporium is probably doing something similar.
Yeah.
Oops. Can you still hear me?
Yes.
Right, we're back. Am I still sharing? I'm not, am I?
No.
Right. Is that filling the screen?
No.
Stop sharing.
It's yeah, it's acting differently. Share. There we go. Okay. There we are.
That's
That
got
should
it.
be it.
Yeah.
Yeah, I think it sounds like the Scedosporium is acting in a similar way to Aspergillus, and it's causing this overreaction, and that's what's causing the plugging, and that's linked to the bronchiectasis. So it's all interlinked for sure.
Yeah. Yeah.
So I think I think you're probably right to make that assumption. Well, we need to know a little bit more about exactly what these fungi are doing in your airways. And we don't think they're doing much other than causing that overreaction. But I guess there's more to know. Now we've got these new tools, we can investigate that more closely. And I'll probably be seeing papers being published in a couple of years on that particular subject a bit more often. So, so antifungals don't cure ABPA. Well, what they do is reduce the amount of fungus in your airways. So they're reducing the amount of allergen in your airways. So they're producing less of an immune response. And it's an indirect kind of treatment. The example given to me yesterday was it's like treating a dust mite allergy by reducing the dust rather than killing the dust, which seems appropriate in this case. But antifungals alone rarely control ABPA because the overreactive immune system is still primed and ready to react. And antifungals are working indirectly. They're not working directly on the inflammation, whereas the biologics are doing that. That's precisely what the biologics are doing, so that's why they work better. So let's Can I change slides? Yep. So, hang on. Yeah. So, this is changing how we see ABPA. ABPA is primarily an immune-driven disease with a fungal antigen as its trigger. It's not a fungal infection with immune involvement, but I think we're all fairly convinced that it's quite a complicated interaction. It's a complicated situation. So it remains a problem for specialists rather than generalists. There's no tissue invasion, except in those few cases I talked about where we seem to get a type of CPA developing in a few people with who have ABPA. There's no fungus entering the blood. There's no destruction of lung tissue by the fungus itself. There's no increased fungal burden when biologics are used. So what you might expect is the inflammation is a response to the fungus. If you take that inflammation away using a biologic, you would expect that to stop the inhibition of the fungus, and the fungus might grow. Doesn't seem to be that doesn't seem to be what happens. The fungus is not thinking, well, I've no longer got an antifungal to fight against. I can grow. When they take away the inflammation, it's logical that the fungus one of the options is the fungus might start growing, and it doesn't. So it furthers the argument that the fungus actually doesn't have an awful lot to do with ABPA directly, because even the inflammation isn't really inhibiting the fungus itself. It's just an allergic reaction to the presence of the fungus. Specialist centres report no increase in fungal growth or colonisation during biologic treatments. Biologics don't let fungus take over, which confirms ABPA is not an infectious process. Our immune system isn't holding back an infection. The fungus isn't trying to infect us. So it's kind of changed our whole opinion of our whole impression of what's going on. What this means for patients is you are not fighting off a fungal infection. You are managing an immune disease that happens to be triggered by fungus. You're treating the immune system can control the entire condition. Biologics are often safer and more effective long-term than steroids or antifungals. So it's great news that they are at the center of reducing all these symptoms attributed to ABPA. Who knows in the future if we can treat people with biologics earlier, we'll prevent a lot of the plugging, a lot of the lung damage as well. Flares happen when inflammation surges, not when the fungus grows. So I think we've said a few times over the years, well, quite a lot of times over the years, someone says, why are my symptoms flaring up if I've got ABPA? We often treat that flare with an antifungal drug. We often say, your fungus must be growing a little bit, and that's what's causing the flare. In fact, that is not what is found to be happening. So we still have to find out why these surges happen. Probably bacterial infection plays a major part, but it's not the fungus, apparently. At the moment, this could change in the future. Where the science is heading, researchers think ABPA is closer to SAFs, severe asthma with fungal sensitization, eosinophilic lung disease, which makes it eminently treatable with biologics, and type 2 inflammatory disorders. There's an ongoing discussion that ABPA may eventually be reclassified as a fungal allergic immune disorder rather than a pulmonary aspergillosis, because the inflammation, not a fungal invasion, is what injures the lungs. The fungus is the trigger, not the cause.
Not the cause.
Clearly, there's still some issues here with this logic, this stream of logic. Why are the antifungals helping so much if it's nothing to do with the fungus at all? But there's a certain amount of refinement is needed. Biologics don't kill Aspergillosis. They calm the immune system, yet ABPA improves dramatically. This tells us ABPA is not really a fungal infection. It is a severe allergy immune overreaction. It's driven by inflammation, not fungal growth. Therefore, biologics treat the true root cause, which is why the biologics have so far been such a revolution. And there'll be more to come, I'm sure. So what happens to the fungus when symptoms are reduced? As yet, we don't really know. And we've got some hints, like I've just been talking about, but this is an area of research that is probably coming next. Evidence here is that there is increased fungal growth in the ovaries of an ABPA patient. So antifungal medication will continue to play a role in treating ABPA for the moment. You can see how these two situations almost contradict each other. It's a complicated situation, but we are gradually managing to find out what the true answer is, and biologics are improving most people's lives so much. You have to say there's about 15% of people who take biologics aren't helped by them, so there's got to be more than one or two things going on, and we have yet to work out what those are. It's not the end story, but it's the next step in the story. Okay, that is the story and when you think about it, NAC and ABPA, NAC and is essentially a service that is staffed by people who are infectious diseases specialists. We also have respiratory disease specialists who run the clinics if you've got ABPA. If the fungus isn't acting as an infection, then it's not really the domain of the infectious diseases people to treat. It's the domain of the respiratory people to treat. So at the moment, it's looking like respiratory is winning, and that's why that's why there's a difference between the two specialisms. The respiratory people are all about asthma and controlling inflammation with their array of drugs that they use. Infectious diseases people are all about treating the infection that they think is causing the issue. So ABPA has slowly become, or is becoming, a respiratory problem rather than an infectious diseases problem, and that makes a difference on which specialist that you will see. Already right now, you will see, if you come here for ABPA treatment, you'll be seen by almost always by a respiratory specialist and not an ID specialist. CPA, on the other hand, is a totally different thing. But ABPA is sort of, we're gradually finding out where its place is, and that seems to be what's going on. Right, that's all I wanted to say about that. Got half an hour. Beth, have you got anything you want to talk about for half an hour?
Not for half an hour, just had a couple of quick reminders. Yeah. So just on the subject of severe asthma, next weekend, I think it's Saturday, ELF are running their patient conference for severe asthma.
This is back number 2, and I'd done the wrong size. It's quite a loose jumper anyway. No, I can't remember. I checked for some reason. My knitting was awful because I don't knit very often, and I also realised I'd made the neck size up, so I undid it, made the front, and this is back number 2, and I've done the cuffs. It's just a warm. It's actually wool. So
full colour.
Yeah. Yes, I love the colour, and I like the blue with it too.
Yeah. I'm making a little jumper for my friend's baby.
Oh, much quicker. Oh, that's fancy. Very good.
Right.
Sorry, just had to make it about knitting for a second.
Okay. Can everyone see that slide now? I assume you can.
Yeah.
Okay, so another subject that came up during the week was the often repeated impression that young children are a nightmare when it comes to infecting you with you always seem to get ill when they're ill. They go to the school and they pass on their infections and so on. And I thought, I wonder how much truth there is involved in that, and just to be clear, what are the worst risk factors and how we might cope with it. And the outcome was pretty much as you might expect. People with ABPA and Aspergillus-related asthma and bronchiectasis have noticed they become ill far more often when spending time around younger children. Why is that? This applies to whether you work with them, live with them, or spend time with the grandchildren or family groups. Okay, so here's why it happens. You probably already guessed a lot of it, but just to get it into a structure. Notice the limitations of AI in certainly drawing pictures. It's decided to put in a euro sign there in the middle of my word, but never mind. Young children spread far more respiratory infections, so children under 11 are the worst. They carry more colds, more viruses and respiratory bugs. I imagine that's what we'd all noticed, but what we might not have noticed is they shed viruses for much longer periods of time than adults. Oops. So not only do they get more infections, they're more infectious for longer. So more reasons why to avoid them when their noses are dripping. They have high viral loads, so they shed viruses for longer, and they have more virus that they spread. These are all reasons why they're so infectious. In behavioural terms, they're not particularly good at hygiene. You do try and tell them to wash their hands and wash their faces and whatever. They will do it some of the time, but not all of the time. I think this was partly written for parents and partly written for teachers. Behaviorally, they spend a lot of time in close contact with adults, so they've got shedding viruses for a long time. They shed a lot of viruses and they stick close to the adult, the poor adult. That is the focus of their attention. So these things together, all these things together, mean that we really need to be careful about catching infections from the little darlings. I can say this now because all my children are grown up, so I'm no longer being infected. Even small, although I do have grandchildren, even small viral infections can cause major lung flares in ABPA and bronchiectasis. We have to be really careful about young kids, around young kids. Viral infections trigger flare-ups, so it's not just the original infection that they give you, it's everything that follows, as I'm sure you're aware. Bronchiectasis, mucus doesn't clear properly, so these infections tend to stick in your lungs for longer periods of time. In ABPA, airways are inflamed, they're very reactive, and they're filled with mucus. So they're more vulnerable to infection. If you're asthmatic, viruses are the most common exacerbation trigger. So if you are asthmatic and you have ABPA and bronchiectasis, you've got no chance. A simple cold in a child can turn into a fever, chest infection, the need for antibiotics, pneumonia, weeks of recovery. And it's not just you. This pattern is extremely common amongst all parents, and I'm going to guess mostly grandparents. I only see my grandchildren outside this time of year. Well, they're outside, I'm inside. So to try to limit infection. Even when they're only mildly ill, some viruses, and this is where RSV comes in, but also adenovirus is a type of common cold, and the flu. they will be spreading those viruses even before they have any symptoms. So even if you're watching out for all these nasty things to come from them, they can still catch you out because they can be showing no symptoms and still be infectious, and infectious for many days after a child appears well. Adults with lung conditions may experience far more severe symptoms from those same infections. And I remember often being told that the virus, I think I told other people, the virus going through your child genetically adapts to that child, leaving you more vulnerable to a worse infection because you are genetically similar to the child it's adapted to. I don't know if that's true or not. That's probably worth a supplementary article about this. Now I've thought about it. I'll do that next time. Any indoor close contact time increases risk. There's no getting away from them. If you're a teacher, you're vulnerable. If you're caring for grandchildren, you're vulnerable. Even just sitting in a car together, going to birthday parties, family gatherings, or even worse, living in the same household. Even short exposures can be enough in the winter months when all the windows are shut, there's almost no ventilation, everyone's packed together, and you've got one child with a drooling nose infecting everybody. I remember it very well. It's not just us again. What other aspergillosis patients report across support groups and clinics, many patients stay well until the grandchildren reach school or nursery age. I think that's a fairly well-known pattern. Switching from high school to primary elementary teaching is something that is often done, recommended to teachers who are particularly vulnerable. So if any of you is vulnerable, is a teacher, you can negotiate, or you might try negotiating teaching older kids rather than those younger under 11s in order to try and cut down on the amount of infections that you get from those kids. People frequently report more pneumonias in winter when around young children. This is very common and it's not your fault. Well, it is if you could have avoided them. How to reduce risk, improve ventilation is the number one. Open windows and doors during visits or lessons. Everyone will freeze. And a morning like this morning, it's probably not very likely that the windows will stay open for long. But it is the number one way to avoid being infected. Use a HEPA air filter, that can help. But of course, it has to be the right size for the size of room that you're in. And it has to be a good enough filter. HEPA's got a number of grades. But if it's big enough and it's pulling enough air through in a room, that can help reduce the amount of virus in a room. And try and keep out of small rooms for long periods of time. The smaller the room, the more concentrated the virus is, the more chance you have of getting an infection. Control exposure without avoiding children. Shorter visits with good ventilation are safer than long indoor contact, presumably with bad ventilation. So that's a tip for older grandparents. Keep it short. I have to go now. I've got a train to catch. Whatever works. Keep up with airway clearance is helpful, vital for protecting infections from settling. I'm not quite sure what settling is. I presume it's something you're inhaling, not sure. A face mask can help, especially when there's high virus circulation. So RSV, flu, and we've just seen flu surging, RSV is falling. These are all winter bugs. COVID is falling. So keep an eye on, and I'll give a resource shortly. You can go to refer to when these viruses are high in the outside world, which point it'd be a good time not to go out. Stay vaccinated, almost goes without saying. And the range of vaccinations you can get: flu, pneumococcal, COVID, and if you're around infants a lot, pertussis is worth having. If you're repeatedly unwell at this time of year, get a medical review. You may be eligible for prophylactic antibiotics. Nebulized saline might be helpful. Make sure you optimize the control of asthma with inhalers and biologics, and check how well your symptoms of ABPA are being controlled. If the exposure is workplace related, we talked about this slightly earlier, ask to teach older groups because they spread viruses a bit less efficiently than the younger children. Ask for ventilation improvements where you're working, and reduced winter exposure. Oops, not quite sure what that means. I suppose it's a general principle. Tracking viral activity. So where to get reliable information on these outbreaks. There is the page what I wrote, which you can find on the aspergillosis.org website. It contains all this information. It contains a list of resources you can use to track the amount of virus there is out there in the environment at any part of the during any part of the year. Lots of different viruses are listed, including RSV, measles. You can even get regional activity levels. If you go to the UK Health Security Agency, UKHCA dashboard, and there's a link on the slide, but if you just type in UKHSA dashboard, you'll find it. I think it comes up as the #1 choice, and that will tell you how things are doing out there in the world of viral surveillance.